wait for you to do that, and then I'm ready to go.
All right. Hello, everyone. Welcome to the InROC webinar series. I am Amna Anwar. I am a Senior Director at Indiana Rural Health Association and the Program Director for Indiana Rural Opioid Consortium. We are currently working in 12 rural cities in Indiana towards the prevention, treatment, and recovery of substance use disorder, specifically focused on the opioid use disorder. And this webinar is a part of our outreach and education. So today's topic is the work that is being done by Groups Recover Together. We have with us our presenters, Dr. Patricia Canfield. Dr. Canfield graduated from the University of Louisville School of Medicine, attended a pathology residency in Cincinnati, Ohio, and is board certified in clinical pathology. She joined Groups Recover Together 3.5 years ago as a group therapy MAT provider and is currently working as a regional medical director. We also have with us Jamie Reckelhoff. Jamie received his master's from University of Memphis in Community Agency Counseling. Jamie joined Groups in 2017 as a counselor in Central Indiana and is currently serving as the clinical director over all of Indiana. In this role, Jamie works with a team of 5 clinical supervisors to provide professional development, training, and policy development to ensure the highest quality of clinical care. And then we have with us Joe Henry. Joe is a graduate of Earlham College with a BA in psychology. Joe has been with Groups since November 2017. His current role at Groups is that of business development manager with a focus on creating partnerships across the state of Indiana that will improve awareness of Groups and give much needed access to those across Indiana in need of the opioid use disorder treatment. Before I hand it over to our participants, I would just like to add that if you have any questions, you can use the chat option or you can use the raise hand option to ask those questions. This webinar will be recorded and will be available on our YouTube channel to access at a later time. So I will hand it over to all of you at Groups.
Thanks so much, Aman, and thanks for having us today. I'm going to share my screen and pull up our presentation. Present. All right. So again, thank you so much for having us today. We really appreciate you to invite us and learn more about Groups. Groups has been in existence for about 6 years, but in Indiana for the better part of 4 years. We started in Indiana, predominantly south in the Lawrenceburg area. And have expanded across the state. We have 25 active sites right now, and we will be at 34 sites in the state of Indiana by the end of this year. I will share this presentation along with one of our Indiana brochures that will highlight all of our locations to make sure that everybody has access to that information. I think the thing that comes to mind when we talk about Groups and what we do is we know that the opioid epidemic's been a huge problem for some time now. It's impacted so many people's lives. It's really hard to think about. It's really probably harder to think about people who it hasn't impacted than vice versa. And so we know that that MAT or medication assisted treatment has been something that has been on the table for quite some time, but the lack of care that surrounds those members outside of just the MAT has been somewhat of an issue, and access to programs that go above and beyond treating the symptoms of MAT haven't really been existent, and especially in some of our more rural communities. We know that's been something that hasn't really happened traditionally. A lot of times you hear about folks that have to drive an hour or two to get to a treatment facility to be in an MAT program. And what Groups does different is that we take that MAT, that gold standard of treatment, and we also combine it with group therapy and building community around our group members. So we're trying to go above and beyond the once monthly check-in. Here's your prescription. See you next month. Go get some counseling. Groups has implemented a program that really wraps around our members in so many different ways to address all of their needs and not just the chemical dependency. Status quo for medication-assisted treatment, like I alluded to, a prescriber who might meet with a patient for 15 minutes to 30 minutes and then prescribe and like I said, go get some counseling, see you next month. The medication is prescribed in isolation with no wraparound, no involvement with peers or others addressing, you know, the other issues that come up when addiction takes hold. Typically, prescribers and especially in rural areas will work alone and lack the specialized training that they need to address addiction. It is very much, you know, it comes across very much as a Band-Aid. And then urinalysis testing is the main source of their reimbursement in those programs, and something that really, you know, kind of overshadows why we want to work with the member to help them address their needs. Our evidence-based model around our 3 pillars of care: medication, care navigation, and therapy. We want to treat the whole person, not just the chemical dependency. We want to treat everything that's going on in their lives and address those social determinants to their health, those barriers that they run into. And we do that by incorporating more than just the MAT into the treatment plan. We use those treatment plans, and I'm going to let Jamie talk about this a little bit more in depth, but we develop those treatment plans with our members, and the development of that starts from the time of the initial intake. Jamie, do you want to hit on the clinical piece and the therapy piece a little bit more in depth?
Absolutely. Is my audio coming through okay, Joe?
It is.
Okay, great. So we just really want to highlight, you know, medication-assisted treatment is a very powerful tool, and it's very great for what it accomplishes. But effectively, a lot of times what that is putting a pause on the physiological symptoms of a substance use disorder. So what we really want to do is when we are using that tool and we're putting a pause on those withdrawal symptoms, lowering those cravings, we look at that as a great opportunity to get in there and work with our folks on developing all of the skills and all of the things they really need to be successful long-term. So we want to pair medication with therapy on a weekly basis for all of our folks, just to give them access to not only the evidence-based material that we're presenting in our curriculums, but also a chance to build a recovery community inside of their group. I always talk to my counselors and I say the best groups you're going to have are the ones where after you say hello, you don't really talk at all. You introduce the topic and you let your group members take it, and you're just there to kind of steer the conversation a little bit. And it's really the goal. Present them with some information, provide some education, sure, but absolutely establish a community of folks who are going through, you know, who are at different levels of recovery, who are at different levels of education, of different experiences, who can kind of help you with whatever it is you're struggling with, and be that source of both support and also a little bit of accountability.
That's why I brought him along. The guy's great. Great example and great description of how we do what we do, and really where the really magical work takes place is in those groups and through that therapy process. But the medication still plays a big role in what we do, and it really has a lot to do with helping our members get to a point where they can focus on all the things that Jamie's alluding to. Our medication model, we have monthly 60-minute shared medical appointments where the provider is in group for the full hour every 30 days. We've actually been doing that throughout the pandemic with our virtual model, which we'll talk about a little bit more in depth at a later slide. We've actually been having providers participate in group each and every week via the virtual platform for the first 15 to 20 minutes. I know that some providers prefer the hour versus the each and every week, but we've tried to make sure that we're engaging with our members a little bit more intimately during this this pandemic, and making sure that they have access to our providers on a weekly basis. Suboxone is the only drug that we prescribe, which is delivered through a protocol-driven system. And I tell you what, I'm going to have Dr. Canfield hop in really quickly to just kind of highlight, the way that our providers interact with the members, and what that prescribing protocol really looks like and consists of.
Our prescribers actually, we have two types. We have the prescribers that sit in group 15 minutes each week. We also have prescribers like myself who sit in group for an hour each month. And when I sit in that group, I pretty much get to know the members that are in this group, because I'm the prescriber and I want to know each one of these members nearly as well as the counselor that I'm working with in the group knows the member who sees them every week. I don't feel confident just handing out medication and then going off and never knowing these people. I think it is important for them to have a relationship with the prescribing provider as well as with the counselor that facilitates group and co-facilitates with me. The medication that we chose to use is Suboxone. It is a combination of buprenorphine and naloxone. It is a partial agonist opioid, and by that it really kind of is a lot stronger than morphine or codeine. And if there is an agonist on board, an opioid, Suboxone comes along, knocks it off, and sits over the receptor and takes over. Now, the naloxone taken sublingually, like we give out the Suboxone, doesn't really do a whole lot, but it does stop the euphoria that one may feel if they were taking just a mono product. So we use the combination across the board. We don't deviate from that, even in pregnancy. In 2016, ACOG issued a statement that naloxone was no longer considered harmful to the fetus. Therefore, we went from Subutex to Suboxone. Members will still ask for it, but we don't use it. The way we prescribe is we see the member, we prescribe enough medication for a week, and we try to abide by the fact that the FDA recommends 16 milligrams of Suboxone a day. So we try to abide by that. We prescribe them a week's worth of medication and we give them 3 refills. Now, if they do not show up for the group the second week, then their medication is canceled. So they not only have to attend group, they have to attend group to get their medicine. And also we ask for a urine drug screen at least once a month, and that is when the provider is visiting with them. Yeah. So when I sit in group, I need to see a urine drug screen from each one of my members, and that's how it works. We don't hold medication because they may have relapsed. We don't do that. We try to get them more counseling, maybe some one-on-one. Sometimes I meet with them individually, but we don't hold their medication. We help them through medication, but our main concern is that counseling piece.
Mm-hmm. Yeah, very, very well stated, Dr. Canfield. And just a couple of things that she was alluding to. Those urinalysis screens are, like she said, at least once a month, but by and large, they are happening each and every week. The members, like Dr. Canfield noted, are required to attend their group each and every week. to continue to receive their weekly prescription. Our office staff do a really good job of working with the members, because we know life comes up, like things happen, work schedules change, kids get sick, cars break down. We understand that, and we work really hard to find times that they can make up a group if they're not able to come to their regularly scheduled group. All things that we try to do to make sure that we're meeting the member where they're at, to keep them successful in recovery, because at the end of the day, there are a lot of things that can derail recovery. We've got to be that constant to help them stay on track and stay in the program so that they can get to where they want to get to. One of the things that I also wanted to highlight in regards to our medication piece is that we take diversion really seriously. Part of our weekly screening process includes that they're testing for buprenorphine to be in their system. So we want to make sure that buprenorphine is showing up. We also conduct random pill counts, where we bring in 15% of our caseload at any given off-site each and every month, where they're asked to present with their medication, take an additional urine screen that again is checking that buprenorphine's in their system. And diversion is something that we know we have to take serious, because we don't want to taint a really good program with folks taking advantage of using the medication in the wrong way. So in those instances, we would to do an automatic discharge if we find that there is diversion taking place. Jamie and his team do a phenomenal job of working through those instances on a case-by-case basis and really getting down to the nuts and bolts of what's going on and why things might be the way they are. But at the end of the day, it is something that we take very seriously, and we don't really waver on that. We wouldn't, if it came to an automatic discharge, Jamie and his team would work really hard to find a way to refer that member to a higher level of care, because obviously the program that we have in place for whatever reason for that specific member, wasn't working. We recognize that on all fronts, not just the diversion front. That's something that we do on the regular. So making sure that the program is a correct fit is always addressed by our counseling staff. We want to make sure that we've got them in the right place. And then my role kind of comes in creating partnerships with organizations that can offer that higher level of care, and other organizations that can address things like mental health. I want to talk real quickly about navigation. That is the third piece of our three pillars, and it is no less important than the other two. We have dedicated care navigators that are working remotely, so they're connecting with members. Specifically in the first 90 days, they're reaching out to connect and establish a relationship with them, and to try and meet their needs outside of group and the MAT that we offer. We've got 7 supporting Indiana right now, 7 full-time care navigators. They connect with the members via phone call, via text, via email. They work really hard to connect the member with services and resources. We've got members that come to us that haven't probably seen a primary care physician in years, or a dentist, or gotten help with the mental health issues that they need help with in years as well. And so, part of the weekly touch base, the weekly group it doesn't stop at the medication and the group session. We know when there are red flags coming up and things going on in their lives that they need to address, on top of the treatment that they're getting in our program. And so we've got to have partners. We've got to have partners to refer to for primary care providers. We've got to be partnered with dental options. We've got to partner with mental health providers. And so, again, part of my role is reaching out, trying to connect with those community organizations. We don't want someone in our Lawrenceburg office to have to go to Cincinnati for mental health services. We want to find a provider there in their community, that's willing to work with us and willing to work with the member and, address all of their needs and not just the needs that are associated with addiction. Members can access our call center, which also serves as a crisis line. Our call center is open 24/7. They're taking calls around the clock, and they have the capacity to connect those members with a licensed mental health professional or a licensed substance abuse counselor in the event that they are experiencing a crisis. And like I said, that is around the clock. We've got clinical staff on call. And a lot of our care navigators are actually functioning in a peer role. They are much more a peer than they are a counselor or a provider. A lot of the folks that are in our care navigator roles have gone through addiction or struggled with addiction, and can really connect with those members, on a more intimate basis, and really identify with them and help them address their needs. Some of the examples of the needs they're trying to address could be the things we've talked about, referrals out to healthcare and mental health, or it could be things like helping a member navigate a DCS case to try and get their kids back in the home, helping a member rewrite their resume so they can apply for a new job or apply for a job in general, trying to help them obtain housing, or even clothing and addressing food insecurity. We have a great story. I can't remember exactly which offices, then Jamie might be able to jump in and help me. But in one of our offices, we had a young lady who was doing pretty well in the program with us and in a good place in her recovery. For whatever reason, her husband left her and her children. They had nowhere to go. And our care navigation team really stepped up, helped her find housing, helped her find a job. And throughout the whole ordeal, she never missed a group, and has stayed in group with us and has done really, really well. That could have gone in the other direction drastically. We could have lost that member and never seen them again if we didn't have that care navigation piece in place and access to all the resources that team has access to. So just a great example of our program can really wrap around somebody in addition to the addiction treatment that we offer and that we do so well. Dr. Canfield or Jamie, you have anything to add there before we move on to the next slide?
I'd just like to say that sometimes law enforcement, the courts, and sometimes just the general public looks at an organization that distributes Suboxone as a pill mill. And in reality, sometimes that's true, unfortunately. Groups, however, is not that way at all. If we were to be looked at as anything, we would be a counseling service that offers medication-assisted treatment rather than a medication-assisted treatment program that also offers counseling. So our primary goal is our counseling, and our medication-assisted treatment is actually secondary.
Yeah, it's great point, Dr. Canfield. The MAT is very much in addition to all the other things that we offer, and how, like I mentioned before, we treat the whole person. Going back to so this slide really talks about the member journey, excuse me. Kind of outlining what one would expect from the time they make that first call into us, and then through to ongoing recovery. Like I mentioned before, we have a 24/7 call center that can act as our crisis line, but primarily is for scheduling intakes and connecting those members with that rapid access to care. We know that sometimes that window for somebody to recognize that they want treatment and want to get into treatment can be very, very small. We refer to the overdoses, whether an overdose run is done by an EMT or an overdose victim is then placed in the ER. We know that at that point, when they come back to, there is that small window of them seeking treatment, and we want to make sure that we're there, in that event. We don't want them to have to wait. If it happens at 2 a.m., we don't want them to have to wait until 8 in the morning to make that call. We want that call to be able to happen when they're ready, at the time that they're ready. The initial intake appointment is always done with a counselor. It's a full biopsychosocial assessment. And right now we are meeting a goal of 24 to 48 hours from the time of that first call. So if that's at 2 a.m. on a Friday, you know, we're meeting a goal of having that member in front of that intake counselor within that 24 to 48 hour window. We've got fully licensed counselors that make up our centralized intake team. They conduct all those intake appointments virtually through the Ring Central app that Dr. Canfield alluded to earlier. You know, we are working with some specific locations across the state to be able to still offer members that might you know, have technology as a barrier to come in and conduct that intake in the office. And really the way that would happen is they would come into the office, obviously fully masked, and use one of our computers there in the office to do that virtual intake. So we want to make sure that when technology presents as a barrier, we do everything we can to eliminate that barrier. Like I said, that first intake appointment is with the counselor. Full biopsychosocial assessment takes about an hour to an hour and a half. Once that's completed, and the counselor deems that member would be an appropriate fit for our program, they would then talk to a prescriber and have an appointment with them, which is also done virtually and typically is same day as that counselor intake. There might be some instances where it's the next day, but by and large, those appointments are happening same day. And that appointment's about 25 to 45 minutes. If I'm off base, I'm sure Dr. Canfield will let me know, but it's about 25 to 45 minute appointment that really focuses on the medication management piece, really trying to address the needs of that member in terms of use and appropriateness, and then, you know, trying to nail down the dosage, and then making sure there's no other medications in play that could interact poorly with the buprenorphine and naloxone, or any allergic situations. So like we said before, Suboxone is the only medication we prescribe to, you know, in terms of MAT. Once that intake process is completed, then we've got a group schedule at each and every one of our offices. We've also got a group schedule for members that might, you know, continue to be virtual only once we go back in person. And those group offerings are all times of the day and week. We try to make sure that we have openings for first, second, third shift, trying to address, give you know, mothers that are in the home maybe the opportunity to come in the evening after their spouse has gotten off, or vice versa. You know, if the caregiver for the kids is the male partner, the same exact opportunity. But we have options all throughout the week and all different times. One of the big advantages of the virtual model is that if a member is unable to be at their group for whatever reason, and there's not another offering from that particular site, you know, we've got 25 other sites that have group times all times of the week and in the evening, in the morning. So we can, right now, it's actually eliminated some barriers in terms of making sure folks are attending group. And we ask them to select a specific group that they're going to stay with each week. Like I said, we know things happen, but we want them to pick a specific group and stick with it. And then ongoing recovery support, the care navigation team, the peer services that includes, connecting them with primary care providers, all the things that go along with connecting with them each and every week, and outside of group and that care navigation piece. It's just so powerful. We'll go on to the next slide. We've talked about virtual model a couple times. You know, when COVID hit about a year ago, I think this time a year ago, we were on total lockdown. And so within 2 weeks of the time that we went, that the country kind of went on pause, the groups recognized that if we didn't do something, we were going to have a lot of members that had no access to treatment that they've been so involved in and so successful in for such a long time. And so we weighed the risks and the rewards, and identified the things that would be hard to do, and decided that we would put a virtual model in place that would keep everybody going in recovery. It's been really successful. Like we alluded to before, rapid intakes, 24/7 crisis support, that's still happening. All of our prescriptions are sent to the pharmacy via e-scribing, like Dr. Canfield mentioned earlier. The Ring Central app is HIPAA compliant, and it provides a platform similar to this Zoom meeting and this Zoom call that we're on right now that allows the members to come into group and participate the same way that they would in person. I mean, obviously, they don't get that in person right now, and there's some that are really craving it and can't wait for us to go back to office. But this has been the next best thing. They still get to keep that group feel and that cohort feel, and they still get to support each other and work together through their issues. Care navigation has continued to happen, and along with that is the peer support and the regular check-ins from folks that have been through it. Basically, we've maintained a steady presence in our members' lives during the pandemic. We've delivered over 150,000 hours of care. We actually analyzed those 150 hours of care, and I've got another slide that kind of talks about the outcomes that we saw even through the virtual offering and how it compared to the outcomes that we were seeing in person. So we're really pleased with the virtual model we've offered. We do note that the urinalysis has been a little bit tough and not ideal. Our solution, it was the only solution that we could really come up with, and the only option that we really had was to locate our urine screens, our instant cups, a 12-panel instant cup, in a lockbox at the physical site. For those that weren't close enough to a physical site, we were able and willing to mail them their urinalysis screens for the month. The member will conduct that screen on their own at home, and then take a picture of that, send it into their office manager, who reads the results. Like I said, we know that it's not ideal, but it was a small snafu in being able to continue to deliver quality model of care and keep people in active recovery rather than the alternative, which none of us wanted. I have learned that we are piloting mouth swabs in a couple offices in Indiana, and we are planning to have a better solution for our urinalysis and drug screening process, because we know the telehealth model and the virtual model is not going away. It is here to stay. So trying to address that and make sure that that's still something that we can do and that we can deliver with validity. So about the outcomes that we see. And so this is a great slide that really highlights our outcomes. Groups, we drive industry leading outcomes with respect to retention, attendance, and abstinence. You can see groups results versus the industry average. The benchmark in MAT is typically to look at retention at 6 months. We know that if we can get someone to 6 months, they're going to be really successful, and that is the marker, so to speak. The first 3 to 5 months are tough to keep folks engaged and keep them on the right track and keep them in a good place. But we know if we can get them to 6 months, that we're going to be successful. Groups have seen a retention rate of 65 to 75%. We're falling inside that window at 6 months, and that actually includes our outcomes in the virtual care model. We're seeing 89% attendance rates or higher with our weekly group sessions from our members, and 90% abstinence rates from opioids with the same group. So you can see at times we're tripling the industry average on all three benchmarks, and that's something that we're really proud of, and we know that what we're doing is making a difference and making changes in the folks that we serve's lives. So yeah, I think this slide really speaks for itself. Outcomes that we're happy to report. This slide talks about the range of partnerships we've created in each and every community that we've been in. emergency departments. We've connected with emergency departments to make sure that we can be a resource for them when those overdoses show up. We're even engaging with emergency departments to help them set up a protocol to conduct Suboxone on the site with that 72-hour emergency waiver from the DEA, and then we can slide in as a partner and get that individual in for an intake appointment inside that 24 to 48-hour window that we were talking about. So that's something that we're very interested in engaging with, to be a resource for emergency departments. We're willing to even talk through protocols and procedures, even if the hospital wants to take that, the ED and the hospital want to take that up on their own. We would be willing to help them engage in that, and then partner with them to provide a wraparound care after the fact if needed. But either or, we would be willing to support them on an emergency basis, or if they want to come up with their own induction strategy and then look to us, after the fact, that's something that we're willing to do as well. We've got a lot of materials that can talk about what that looks like. We've got providers that have set that up and done that specifically in Maine, that have had a lot of success and are willing to work with us to share how they got to the place of having that success. So first responders, I've talked to a few first responding units that are even engaging in potentially offering induction on site when they make their runs to an overdose. And so trying to partner in the same way with them if that's something that they are interested in. Local primary care providers, like I said, we need to make referrals to them all the time. Criminal justice is another big partner. I mean, really, if you look on this list, there's not an entity that we really don't touch in terms of the community organizations that run into folks that are struggling with OUD. Crisis and step down facilities, mental health providers. So really just it's a really nice slide to talk about and show who all we're partnering with and who we're willing to work with. It really doesn't matter who. Great. I've got a question about can we share where all of our Indiana physical locations are? I will come back to that at the end. I can rattle those off. I've also got some information that I can share out. I've got an Indiana brochure that highlights all the locations, but I'll be glad to list those off when we get to the end here. Thanks for the question. So if there's somebody that you think could use us as a resource, or that needs to know more about us, I am more than willing to connect with them and talk about how we can be of a help and a resource to them and the community in general. Going on to the next slide. If I can get my finger out of the way, let's hide this. All right. Like I've mentioned, through the partnerships that we create, we're better able to address the needs of the members and facilitate that high quality care through timely access. We've mentioned the 24/7 access line a few times. That is something that we're really proud of. Speed to care, we're continuing. We've never had a wait list in the history of our company, and we'll continue to meet that 24 to 40-hour window. I honestly think that by the end of the year, it's realistic to think that we might even be able to bring that time frame down even more, because I think that there's the possibility for us to offer intake appointments even on weekends. So I think that is a reality. And then our follow through it's unmatched, to be quite honest. The regular weekly touch points, the ability of our counselors to address our members' needs, even in between, even in the middle of the week. Our counselors have done such a great job of being accessible to the members throughout the week, and and touching base with them and trying to help them deal with life that comes up outside of that hour of group. And then our care navigation team, really the amount of touch points that we have with folks is increasing their trust in the healthcare system, and increasing everything about the process is heightened because we were able to touch base with them so often. We get to know them better than than a lot of the people in their lives, honestly. And so that's why what we do is so powerful. Slide talked about how we can help EDs improve access to treatment and get folks into long-term recovery, so that hopefully we can address that revolving door that emergency departments see so often. That is something that we know it pulls on that staff, and it can be very draining to have to continue to address those needs week in, week out. And we hope that we can offer a solution that allows, and I mean, it's a drain on the individual as well. Can only imagine what they've gone through. And so just the that cycle of hit the ER and then cycling back rather than getting them into an option for care is something that we know exists, and we just want a resource to help alleviate that. We would love to create community referral partnerships with emergency departments where able. We know that discharge planning is a complex process. We know that sometimes, especially in the rural communities, there can be wait lists, there can be hoops to jump through to get into care. Like I said before, 24/7 access, 365 days a year. We can connect to multiple offices and create rapid access to intakes in 48 hours, which falls inside of that 72-hour emergency window that emergency departments are allowed to prescribe buprenorphine if needed. And then again, like I alluded to prior, we have the ability, we have the ability to provide that team, that ER, if they're interested, with consultation and strategic support. We don't have to be the preferred provider that the ED partners with for us to just help them work through this process. We know that induction at the time of overdose, when the member or the potential member identifies that they want treatment, we know how powerful that is. We know that the chances of them getting into recovery skyrocket if that's available to them at that time. And so, our mission is to obviously bring access to care to as many folks as we can, and it doesn't mean that it has to be with us. We know our program works. We know it's a good program, and that we can support them in recovery and help them. But at the end of the day, we want to make sure that folks are getting into treatment when they want to, and whether that's with us or with somebody else, it doesn't really matter. So even if an emergency department or ED is even remotely interested in just having the conversation about this and what it looks like, is willing to be that partner and help them through that process. Like I said, whether we're the preferred provider or not. I mentioned earlier some of the outcomes that we've seen with our virtual care. We went to the virtual model by the end of March in 2020, and we looked at those results from the end of March through the end of August. That was the 150,000 hours of care that I alluded to prior, and you can see the outcomes that we've had. Like I said, they mirrored the outcomes that we were seeing in person. We took a pre-COVID in-person cohort and compared it to our virtual care. You can see in the groups to the right, very similar in age, gender, duration of use, and how many members were actually self-pay versus Medicaid or commercial members. Our virtual cohort saw attendance rates of 83%, just like our in-person group. Abstinence for illicit opioids was at 97 compared to 95. And retention, again, fell into that 65 to 75% window we talked about before. So numbers we're really proud of that showed that, we made the right decision when we kept our groups going and kept things going in a virtual capacity. I promise I'm getting down towards the end. This is our last slide for the day. this one, I just threw this slide into the deck because I felt like it's important to note that yes, we are an OUD provider, but our program and MAT in general has still had a positive effect on some polysubstance use, and not just opioids. Being admitted into the program does require a member to have a history of active use at the very least, and I'll probably let Jamie expand on that just a little bit more. But we do have members that come to us that at one point were actively using opioids and for whatever reason have switched over to methamphetamine. We know that that's an issue. It comes up a lot. The third-party research that was done found statistically significant reductions in stimulus use post their initiation of treatment with us at groups. At intake, 7.2% stimulus in the last 3 days, and then after a month was down to 1.8, 3 months 2.1, and 6 months 1.8. So it was significant. It did show that there was a difference for those members that were in treatment with us. And like I said, I want to let Jamie just expand a little bit more, because this question comes up a lot. We know that stimulants and methamphetamine is right now it's a huge issue, and it's coming up a lot. And so I want Jamie to kind of just address the scenario a little bit in which we would work with somebody that's fallen into that bucket.
Yeah, absolutely. In order to be admitted into our program, you need to be diagnosable with an opiate use disorder. So our primary focus is clearly on opiate use. One of the things we see very commonly for folks who struggle with continuing to have positive substance in their screens, we have something around a 96% abstinence rate for opiates within the first 30 days. But other substances can be a little bit more complex. So what we do is we work really, really hard pairing our clinical providers, our counselors with our medical providers to try to ascertain both, A, is it safe? Is their usage pattern of whatever it is, whether it's amphetamine, stimulants, or benzodiazepines or what have you, is what we're seeing for them medically safe? And if it is, that's when it gets turned over to the clinical team to do our best to try to determine what's the best outcome we can get for this member. We work very hard to not be reactionary. We don't have a 3 strikes you're out policy or anything that kind of prescriptive when it comes to drug screens. We instead rely on our clinicians to ascertain what's going on with that person, right? Are they benefiting from the program? Are they participating in group? Are they attending regularly? Yes, they continue to show positive for other substances, but if they're making a clear indication that they're benefiting from treatment, then we're going to try to continue working with that person. And like Joe was alluding to there, we've seen some good results in reductions of stimulant use, even for folks who have just come right out and said, well, I'm only here for opiates. I'm not worried about my meth use. Even those folks, we've seen some really good work with that population as well.
Thanks, Jamie. I appreciate that. Much more well done than I could have come up with. I am going to take an attempt at rattling off all of our locations really quickly. I know that was a question that was asked. Like I mentioned, I'm going to send this presentation to Aman and Heidi, and so that they can send it out to the group if someone wants it. And I'll also include our Indiana brochure that lists all the specific locations. Jamie and Dr. Canfield, feel free to jump in and help me, but we have offices in Lawrenceburg, Greensburg, New Albany, North Vernon, Seymour, Greenfield, Connorsville, Richmond, Newcastle, Muncie, Marion, Kokomo, Warsaw. I promise I'm going to get close. Greencastle, Anderson, Martinsville, Bedford, 2 offices in the Bloomington area, Terre Haute, Vincennes, Jasper, Salem. I know I'm close. That's most of them. Jamie, Dr. Canfield, who am I forgetting? Who am I leaving out?
I don't know. You confused me because you did not go in alphabetical order. So I was
No, I
completely
didn't.
lost. But I think you got most of them.
Right on. I was close. I know we have 25 currently. We'll be up to 34 by the end of the year. And that is the majority. I'm sure I left somebody out in the process, but that is the majority. We'll have offices opening in 9 other sites, and so, like I said, I'll send that out to make sure that everybody has access to that and they can see it. We've got another question. Yeah. I'll go ahead and read it, and then Dr. Canfield and Jamie, feel free to jump in and help out. Presuming some of your counselors are LCSWs, also presuming some or most are Indiana-based, if in fact that is the case at groups, following SB 82 in the Indiana General Assembly currently, this bill would allow LCSWs to execute at the top of their education level and thus diagnosed with oversight. This no doubt would benefit groups. So, Jamie, I'll let you kind of address that. It really sounds like somebody Deanna's really just trying to help us out, honestly. But Jamie, do you?
Yeah, I've seen that. I was very excited to see that. That's been a pain point. I mean, not just for LCSWs, but it's been a pain point for all of addictions licensure forever. So I would be thrilled to see that at groups. All of our diagnoses are confirmed by our medical providers, so by our nurse practitioners and our practicing physicians. But that would definitely help simplify some of that admission process for sure. That's a great question. Thank you.
Absolutely. Any other questions?
I just have one question, and I think Dr. Canfield alluded to it in the beginning as like when an MAT provider is moving into a community, they usually come with a stigma attached of being pill mills and stuff like that. And we have come across that a lot in rural Indiana with our program. So when groups decides to open a facility in a community, do you do any community outreach in the beginning, or like how do you deal with that stigma, and how do you make the community come on board with your facility and the services that you're going to provide?
That's a great question. We've tried really hard to connect with the community prior to opening. We have a list of community stakeholders and the folks that are in the community. We always want to meet with the mayor, with the police department, with the sheriff's office. We always want to connect with them prior to opening. One of the last things that we ever want to happen is for us to open up shop and nobody to know we're there. We don't want to fly by night. We want to engage with the community. We want to connect with them. Like I mentioned before, we want to create these partnerships with the hospital, with the jail, if it's possible, with the primary care providers that are in that community. We don't want to have to send folks to the next town over for their mental health or their physical health needs. We want to partner with everybody in that community to really impact the community in a positive way. Like we talked about before, in a lot of rural communities, there aren't resources like MAT or other resources in general. And so the more we can do to help them stay in the community they live in and interact with that community and get back to a life where they are, helping to contribute and getting back into the workforce. And, that's what our goal is. Obviously, we want to, treat folks and be successful with them in group therapy but along with that come positive impacts on the rest of the community. And so, we absolutely want to connect. If there are, if you are watching and you think that you'd like to connect with us, please reach out. We'll surely share my email and contact information for everybody. So, I'm glad to come down to anywhere in the state for in-person meetings. I'll do virtual meetings, but however we can connect to make sure that you know about us and how we can help, that is the goal. And so I'm glad to serve that purpose.
Thank you so much, Joe, Dr. Canfield, and Amy for your presentation. As we mentioned earlier, it was recorded and will be available on our YouTube channel. And I'll share that link with you as well. Thanks again, everyone, for joining. Thank you.
Thank you.
Bye-bye.
Thank you, guys.